Hello everyone, my name is Anthony Meddock and I'm a faculty member in the Ultrasound division, and today we're going to be speaking a bit about hepatobiliary ultrasound. This is a brief overview of our approach today in terms of our discussion. We'll talk a bit about some relevant anatomy, then we'll go over the technique step by step in a bit of detail so you have a better understanding of how to perform the exam. We'll review some examples of pathology that you might encounter in the emergency department, and then we'll wrap up with some pearls and pitfalls that you should hopefully seek to avoid moving forward. By way of introduction, as you know at this point, ultrasound obviously is a quick and safe modality that is used on many different applications in the emergency department. It can be used to expedite patient care, and specifically as pertains to patients that have abdominal pain, it has many applications, including the evaluation of your patients that may have right upper quadrant or epigastric pain, that have new jaundice, or that have new or worsening ascites. Here's a nice illustration of some relevant anatomy. Obviously today we're going to be focusing on how to identify the gallbladder and the common bile duct, and just remember that the gallbladder and the cystic duct will course and combine with the common hepatic duct to form the common bile duct that will traverse along just adjacent to the portal vein and ultimately will terminate by draining into the duodenum. Additionally, in terms of other anatomic key concepts that we should discuss, I just want to touch on a couple of quick things. First of all, I'd like you to recall what comprises the portal triad. That's going to be the common bile duct, the portal vein, and the hepatic artery. Although we won't be specifically looking to identify the hepatic artery as part of our bedside ultrasound exam of the hepatobiliary system, it is relatively easy to identify the portal vein, and once you find the portal vein, if you know that the common bile duct is just adjacent to it as part of the portal triad, it'll make it much more easy to identify. And the common bile duct is a particular structure of interest with this exam. Further, the common bile duct runs just anterior to the portal vein prior to entering the duodenum. And again, this will be important when we're trying to identify the common bile duct as part of our hepatobiliary ultrasound exam. Lastly, one thing that I'd like to point out is that there's a lot of anatomic variation in terms of the position, shape, and size of the gallbladder, which unfortunately can make this exam a little bit difficult at times and somewhat frustrating, because if someone has just eaten or if someone is overweight, it can make the exam a bit more challenging. But in terms of my perspective, if you're aware of this ahead of time, there are certain measures you can take to mitigate that and hopefully give you greater success. And we'll go over those as we move forward, going through the step-by-step technique. Now let's talk a bit about technique. Ideally, you'd like the patient to be NPO because, as you well know, bowel gas is going to lead to impaired image quality simply because the sound energy cannot penetrate through the gas. In terms of the equipment you're going to use, any type of low-frequency transducer that you have on your ultrasound system will be appropriate. You can use a curvilinear probe or a phased array probe. Either will give you reasonable images. In terms of patient position, I oftentimes do this exam with the patient supine, but if you're having particular difficulty getting good images in good windows, you can place the patient in a left lateral decubitus position and use the liver as an acoustic window so you can get better images of the gallbladder. And much of this is just going to be based on your own experience and the patient's body habitus. Now, in terms of doing this exam, the first thing we're going to want to do is find the gallbladder. Now, there are many different ways to do this, and I'm not proposing that the steps that we are going to discuss in the next few slides are the only way, but this is the way I do it, and I have had reasonably good success. So I propose, if nothing else, this is a starting point, and you can modify this technique as you go, as you yourself obtain some additional experience at the bedside. I generally will start by placing the probe under the costal margin in the midclavicular line. I'll have the marker dot oriented towards the patient's right, and then I slowly fan the probe in a craniocaudal orientation until I can see the gallbladder. And when you do, you'll get an image that looks similar to this. As you can see, this is the liver. This is the portal vein, which we'll talk about in more detail in the coming slides, and particularly you can know that because of the very echogenic walls that you can see here. And then lastly, you can see kind of this pear-shaped structure here that is largely anechoic, and that is the gallbladder. Now, in terms of finding the gallbladder, it's not always that simple. If you see the gallbladder with the steps that I outlined a moment ago, that's great. If you don't get frustrated. One thing you can do that's rather easy is you can ask the patient to take in a deep breath. As the patient breathes in and out, their diaphragm, of course, is going to go up and down. And as their diaphragm comes down, that is going to bring the liver and Also, the gallbladder closer to your probe beneath the costal margin, and oftentimes that'll be sufficient to bring the gallbladder into view. Once you've found the gallbladder, then you want to make sure that you get both longitudinal and transverse views of the gallbladder, and so you just simply want to rotate the probe 90 degrees from one orientation to the other so you examine the whole structure. Once you've obtained a long view of the gallbladder, then you want to gently manipulate the probe to verify communication of what you think is a gallbladder with the portal triad. Sometimes you might mistake a loop of bowel to be the gallbladder, and by just taking the time to identify your gallbladder, again, this is fundus of gallbladder, body of gallbladder, and neck of gallbladder. In general, the gallbladder neck should course towards the common bile duct and the portal vein. If it doesn't, or it courses in another direction, you might be looking at a loop of bowel instead of actually looking at the gallbladder itself. Now, once you've found the gallbladder and you're certain you have the gallbladder, then you want to scan the gallbladder in multiple longitudinal and transverse planes so you can look for some evidence of pathology, including gallstones. You want to assess for gallbladder wall thickness, and you also want to assess for fluid around the gallbladder, which is known as pericholecystic fluid. Here's an example of a normal gallbladder. This is a normal gallbladder in the fasting state. So you can see this very nice thin wall. There's no fluid around it. There's no stones within the gallbladder. Based on this one limited image, everything appears to be within normal limits. This is a postprandial gallbladder, so it's also normal. However, it's important to note that if someone has recently eaten, the gallbladder will be contracted, and that will sometimes give the false appearance that the gallbladder wall is abnormally thickened. But if you don't have any pericholecystic fluid, you don't have any pain upon palpation of the gallbladder, and there's no obvious cholelithiasis, be wary that this could in fact just be a fake out of a postprandial gallbladder as opposed to an abnormally thick and inflamed gallbladder wall. So, once you've identified the gallbladder, then again, as I said, you want to look for evidence of pathology. Now, one of those is going to be the presence of gallstones. Now, gallstones are going to be hyperechoic. They will have what's known as an acoustic shadow, so you'll see kind of this blackened area of anechoic signal deep to the structure. And those are two findings that are consistent with gallstones. Now, in addition to this, gallstones are generally going to be dependent, so they're going to move with gravity. This is a cool video clip where you can see the sonographer is actually moving the patient, and as they rotate the patient over onto their side, you can see the gallstone in a dependent fashion just moving along freely within the gallbladder. So clearly, that is not a polyp, that is not a malignancy, and that is not an impacted stone, because as the patient is being moved and rotated on their side, this gallstone is freely, in a dependent fashion, just traversing along within the gallbladder itself. Now, if you look for just a hyperechoic structure within the gallbladder, you can sometimes be fooled because gallbladder polyps and malignancies can have a similar appearance, but they generally will not have the shadowing and they will not be mobile. So those are two things that are important to keep in mind. So here is a still image showing a gallbladder with a single gallstone with acoustic shadowing. And again, by acoustic shadowing, you can see this area of anechoic signal that is just deep to this very echogenic signal. So this is a gallstone with acoustic shadowing. In addition to that, you can notice the location. This particular signal is located at the inferior dependent most portion of the gallbladder, which is also consistent with a gallstone. Contrast that with this lesion. It's hyperechoic, but you notice there is no acoustic shadowing, number one. And number two, as this gallbladder neck is coursing along here inferiorly, this lesion defies gravity and it is actually adherent to the wall. So this would not be consistent with a gallstone, but this is consistent with, in this case, a gallbladder polyp. In addition to looking for stones, you're also going to want to assess for gallbladder wall thickness. In general, the gallbladder wall will measure up to approximately 4 millimeters. It can be thickened due to multiple processes, including acute cholecystitis, which is what we are most interested in as emergency physicians. But in addition, there are other disease states that can lead to an abnormally thick gallbladder wall, and those include CHF, low protein states, or folks that have end-stage liver disease and are hypo-oncotic, or also patients that have carcinoma of the gallbladder. In addition to assessing the gallbladder wall, you also want to assess for pericholecystic fluid, which is simply anechoic signal or fluid that is layering around the gallbladder. Now again, if you have a patient that has end-stage liver disease and has a large amount of ascites, that ascites fluid will track around the gallbladder as well. So you have to be wary that there can be false positives. But in general, in the right clinical context, when you see an impacted gallstone, a thickened gallbladder wall, and an anechoic signal that goes nearly circumferentially around the whole structure, that's pretty consistent with pericholecystic fluid noted in the setting of acute cholecystitis. Another sign that we often look for, and you may have heard referenced to in the past, is something called the sonographic Murphy sign. And essentially, a sonographic Murphy sign, I like to think of as essentially an ultrasound correlate to the Murphy sign that you would do when you're doing your initial physical exam and palpating the right upper quadrant. However, as opposed to just blindly palpating in the right upper quadrant when you're doing your physical exam, the sonographic Murphy sign involves placing the ultrasound probe directly over the fundus of the gallbladder and then applying pressure. And if the patient has pain during inspiration, or if they stop inspiring at that point during your gallbladder compression, that is a positive sonographic Murphy sign. It indicates that there is inflammation in the area of the gallbladder. Intuitively, this seems like it would be more sensitive and specific than the traditional Murphy sign. However, there's not a lot of data to support that statement. Okay, so now we've found the gallbladder, we've looked for stones, we've looked for gallbladder wall thickening, we have looked for pericholecystic fluid, and now we're going to find the portal triad, specifically because we would like to assess the common bile duct. Remember, the portal triad is portal vein, common bile duct, and hepatic artery. Now, to do this, there's a couple different ways it can be done. I personally like to proceed as follows. I like to find a longitudinal view of the portal vein, which I find is easiest. And once I've done that, then I'm going to want to look for these hyperechoic vessel walls to help me be certain that I'm looking at the portal vein. And as we do that, then we can look for the common bile duct itself. So here you can see this is the liver, this is inferior vena cava, and this is a large caliber vessel running within the hilum of the liver that has echogenic walls, and that is the portal vein. Now, once the portal vein is visualized, you can rotate the probe 90 degrees and you can look at the portal vein either in short axis or in long axis. If you look at the portal vein in short axis, there's something that some people refer to as a Mickey Mouse sign, which will allow you to see the whole portal triad in short axis. And you'll see the portal vein, the common bile duct, and the hepatic artery all in one transverse view. And it looks something like this. So here we have the gallbladder, here we have the portal vein in short axis. This is the common bile duct in short axis and the hepatic artery in short axis. So basically your Mickey Mouse sign refers to the portal vein itself being Mickey's head, for example, the common bile duct and the hepatic artery representing each of his ears. And as you can see, they should be rather symmetric. So that's one way to assess the common bile duct. And you can see how it lies just adjacent to the portal vein. In video, here's what it looks like. Portal vein, common bile duct, hepatic artery. And being able to differentiate one from the other really isn't that crucial. The bottom line is they're symmetric and very, very small, and so you know, therefore, that the common bile duct is not enlarged. And for our purposes, that's sufficient. Now, in measuring the common bile duct, you can measure it in either short or long axis. I personally find that doing it in long axis is a bit easier. So I prefer to find a portal vein view in long axis. And again, remember the portal vein is going to have very echogenic walls, so it'll stand out and be a bit easier to find. Once I found a good long axis view of the portal vein, I will sweep through the area, I will hit freeze on my ultrasound system, and then pretty much every ultrasound system that you're going to have in this day and age is going to have a function called cine, where you can hit freeze and then you can use a trackball or the trackpad to go back frame by frame through the image and look for that common bile duct that is going to be a linear structure in the same plane and just anterior to the portal vein. And when you find that structure, that is the common bile duct. Take a look. So here you can see portal vein. Just adjacent to it, you can see these hyperechoic walls of portal vein and then also of common bile duct running just anterior to the portal vein. Vena cava, portal vein, and then this is a common bile duct just anterior to the portal vein. When you measure the common bile duct, keep in mind that the normal diameter is approximately 5 millimeters. The upper limit of normal increases with age, and it can be up to almost 1 centimeter after a patient has had a cholecystectomy. An enlarged common bile duct and right upper quadrant pain suggests that the patient has choledocholithiasis. Here's another nice image where you can see the gallbladder, you can see the portal vein, and then just anterior to the portal vein, you can see this nice linear structure, very small in caliber, with hyperechoic echogenic walls. That represents the common bile duct. Normal, by the way. If you're uncertain, if it looks dilated, or you can't differentiate between what's portal vein and what's common bile duct, you can always use color flow. And in this instance, you can see this very nice echogenic walls of the structure that has a very robust signal on color flow Doppler. And just above it, you can see that tiny little lumen that's not lighting up at all. That represents a normal common bile duct. Contrast that with this still image here. Here we have the portal vein. Just anterior to it, there is another lumen that looks almost the same size as portal vein, and this is an example of an enlarged, dilated common bile duct. Here's a video clip demonstrating that same pathology, portal vein with the echogenic walls, and then just adjacent to it, which should be a tiny little common bile duct resting just on top of it, is in fact really dilated. Now, if you're uncertain if perhaps that's another vessel, you can always turn on color flow, and if you do, you can see the color flow lighting up the portal vein and not lighting up the structure just anterior to it, because that is a dilated common bile duct. Now, when we talk about cholelithiasis, just remember that ultrasound is a modality of choice for imaging the gallbladder, but also remember that cholelithiasis does not equal cholecystitis. Just because one has stones doesn't mean stones are the cause of your patient's symptoms. There's plenty of literature to demonstrate that we as emergency physicians can become very good at detecting stones with a moderate amount of training, certainly a lot less than you're likely to receive in your residency training. The sensitivity and specificity for a bedside ultrasound performed by emergency physicians looking for cholecystitis is quite good, on the order of 90% in several studies. So we talk about gallstones, remember, they're very echogenic, which just essentially means, again, that they're going to be very bright white. They create an acoustic shadow, and that shadow will be proportionate to its size. They are dependent, and they typically will be mobile unless they are impacted and perhaps causing pathology and some symptoms within your patient. Here you can see we've outlined the degree of acoustic shadowing in this particular gallbladder that is literally filled with gallstones. So here's a video clip demonstrating a single mobile gallstone with typical acoustic shadowing. Now, before a stone actually becomes a stone, oftentimes you may have heard the term that the patient has sludge in their gallbladder. And sludge is essentially just a term describing the lithogenic bile that can be seen in the gallbladder. So it hasn't yet become solidified and turned into a stone per se. It often will layer out in the dependent position, and it may shadow or it may not. It all depends. Here's a video clip demonstrating a gallbladder filled with this echogenic material within it, and that is all gallbladder sludge. Now, other examples of pathology that are a bit more rare, there is something called a porcelain gallbladder, which just has to do with a gallbladder with marked acoustic shadowing from calcium deposition within the wall. Sometimes these patients, in fact, oftentimes these patients may be asymptomatic, and this can be found incidentally. However, there is an association of gallbladder adenocarcinoma with this porcelain type gallbladder, and as a result, these patients would often be scheduled for cholecystectomy. In the acutely ill patient with right upper quadrant pain, the diagnosis of acute cholecystitis is based on the following: the presence of stones or sludge, any notable gallbladder wall thickening, the presence of pericholecystic fluid, and the presence or absence of a sonographic Murphy sign. The likelihood of your diagnosis is going to increase with each positive finding. So essentially, if you have a patient with just stones and nothing else, and the story is not that convincing, your likelihood that you have acute cholecystitis is rather low. However, if you have stones, you have wall thickening, you have pericholecystic fluid, and you have a sonographic Murphy sign, you can be quite certain of your diagnosis. Here's a nice still image representing some classic findings of acute cholecystitis on ultrasound. First, it's quite obvious. You can appreciate this gallstone in the gallbladder neck. You can see the acoustic shadowing. But in addition, it's a bit more subtle, but you can appreciate this anechoic signal tracking here posteriorly along the gallbladder wall, that represents pericholecystic fluid. And in addition, if you look anteriorly, you can see these two markers here. This represents the boundaries of the gallbladder wall anteriorly, which is probably on the order of a centimeter thick, so quite abnormal. So we have gallbladder wall thickening, we have a gallstone, and we have pericholecystic fluid. And that, with the combination of right upper quadrant abdominal pain, gives us a diagnosis of acute cholecystitis. Now, other patients may not have abdominal pain at all. They may have other presenting symptoms in your emergency department. If someone presents with jaundice, obviously that has a wide differential diagnosis. They could have hepatitis, they could have a pancreatic malignancy, but they could also have choledocholithiasis. And this is an image that you're not likely to see very often that's pretty cool. This is the portal vein, this is the common bile duct, which is a bit dilated, and if you look closely right there, that is a stone within the common bile duct, and that is indeed choledocholithiasis. Now, when you have a patient with jaundice, you want to assess particularly and measure the common bile duct, and obviously, as always, you want to examine the gallbladder for evidence of stones. There are also going to be some structures that you may identify and think is actual pathology when in fact they are just normal variants. And here's a couple examples of those. This is what's called a septate gallbladder. So here we have a large dilated gallbladder that's just kind of folded over on itself, and as a result, the wall just kind of has this hyperechoic appearance because you just basically have it folded over on itself, but you notice there's no shadowing. So you don't want to mistake this for a gallstone. This is just a septate gallbladder, and there's a bit of gallbladder sludge that's kind of layering out here. So this is not indicative of pathology. This is a slight variation of that called a Phrygian cap, where basically, again, you have a large dilated gallbladder and the fundus of the gallbladder is folded over on itself, and as a result, you get this hyperechoic appearance right here, but this is not a gallstone. Note, there's no shadowing, and in addition, this is not dependent. If this were a stone, it should be way down here towards the neck of the gallbladder, not way up here as part of the fundus. So this is just a Phrygian cap, which is a normal variant and not indicative of pathology at all. Another thing you might encounter when you're doing your hepatobiliary ultrasound exam is you may occasionally encounter hepatic cysts. Now, a cyst is going to have very sharp, well-demarcated margins. It's going to be completely anechoic within the structure. There will be no septations. There won't be any evidence of material within the lesion itself. And you're also going to note posterior acoustic enhancement. So the area just deep to the lesion is going to be more echogenic than the areas adjacent to it. So this is pretty classic for a hepatic cyst. Now, contrast that with this liver. You see the diaphragm here. This is all liver parenchyma. Here's gallbladder. And if you look closely at the liver parenchyma, it does not look homogeneous. In fact, there are several areas of increased echogenicity. And unfortunately, this is an individual that has metastatic colon cancer. And these are hepatic tumors and metastases, unfortunately. Quite different than the hepatic cyst we saw on the previous slide. So one common pitfall is misidentifying the gallbladder. Sometimes the IVC may have a similar appearance, and you want to make sure that it's not also a loop of bowel that you're mistaking for the gallbladder. Remember, the gallbladder is going to communicate with the portal triad. So if you follow the structure and it tapers towards what looks like the gallbladder neck, and that tends to terminate with the portal vein and common bile duct, then you know you've got the right structure. The other thing that is a common pitfall is inadequate visualization of the gallbladder. You want to make sure that you look at the gallbladder in both a short and long axis, so scan it in two planes, and you want to make sure you get a good view by making sure the patient is properly positioned. You can either have the patient supine, you can try the deep inspiration technique that we talked about, or if those fail, you can rotate the patient left lateral decubitus, use the liver as a window, and come from the kind of anterior or middle axillary line, and then scan from a lateral to medial orientation to get a better view of the gallbladder as another alternate approach. Remember also that all shadows do not equal gallstones. There can be bowel gas. You can have edge artifact, as you can kind of see right here, for example. You see a little bit of kind of anechoic signal here, but that's not from a gallstone. That is from edge artifact. You can also have that from spiral valves within the biliary system as well. So just remember that all shadows don't equal gallstones. Look for the hyperechoic structure with posterior acoustic shadowing. And a very important thing to recall is that any gallbladder that has gallstones does not necessarily mean you have cholecystitis. Gallstones are common. In fact, they're present in approximately 20% of the patients that are over 50 years old. So a lot of people have gallstones. That doesn't mean that they have acute cholecystitis. So in closing, remember that right upper quadrant ultrasound is complex, but there's plenty of clinical experience and literature to support the fact that emergency physicians can do it very well with training and experience. It's not necessary to identify every structure you see on the screen. Remember, this is a focused, clinically driven exam. Ideally, you should be looking pretty much only for the gallbladder, the portal vein, the common bile duct, and then, of course, paying close attention to any irregularities of liver parenchyma, etc. But for the most part, you want to just focus on the questions that you're looking to answer. Don't get lost in the details. Start simple. Identify the gallbladder, identify the portal vein, look for the presence or absence of gallstones, and then if you're able, as you get more experience, try to identify the common bile duct. Assess for the sonographic Murphy sign. Fairly straightforward to do. These are some references used for this presentation, and I'm happy to take any questions. You can always reach out to me via email or also on Twitter. Hope that was helpful. Thanks so much for your attention.